What physical therapists need to know about LCL and posterior lateral corner injuries? What's going on, guys? My name is Dan Pope, and here is Kevin Coughlin. We are physical therapists, and like always, we're doing a literature review. We're taking all the relevant information, and we're sharing it with you, and we're giving you our clinical expertise and hopefully learning a little bit. How are you today, Kevin?
Dan, I'm doing well. We were just saying beforehand that I think this is a topic people are excited to learn about because I feel like we hear about it in school and then you get out in the field and you're like, what the heck is the posterior lateral corner? And what do I do? How do I find it? All I remember is hearing about it, but I have no idea what to do with it. So I think people will enjoy this episode.
Well, today is the day, Kevin. You become an expert at the posterior lateral corner. Yeah, it's like the Bermuda Triangle of the knee. You know what I mean? Yeah, it's going to be a good one.
Good.
We'll start with a little summary. So, like all of our other podcasts, we'll go over prevalence and incidence. We'll go over the common populations, mechanisms of injury, anatomy and pathophysiology, clinical exam, differential diagnosis, and treatments. So, conservative versus interventional or surgical. And I've taken a lot of this from one particular paper. There's a newer one for 2024 called Posterior Lateral Corner of the Knee, an update on current evaluation and management strategies. Let's get rolling on this. So first and foremost, let's talk a little about prevalence and incidence. Is this actually a common injury or is this something that people have made up, right? So this is coming from a study from Laprade et al. In 2007. He's in Minnesota. This guy seems like he is the leading expert on posterior lateral corner injuries if you look at some of the research here. So would love to have him on the podcast at some point. He's a surgeon. And essentially, they were looking at 331 acute knee injuries with hemarthrosis, which essentially means that they had an injury within 30 days and they had blood within the joint, right? They're trying to figure out what type of injuries occur under this scenario, right? And 56% of these folks had a ligament injury. So that was 187 patients, and 67% of those had isolated ligament injuries, and 33% had multi-ligamentous knee injuries, right? So if you have a big old blown up swollen knee after a major injury, about maybe 2/3 of those may be isolated injuries, and about 33% of those are going to be multi-ligament. 44% of those folks had isolated anterior cruciate ligament tears. 15% had isolated superficial MCL tears. 5% had isolated PCL tears, and 2.1% had isolated posterior lateral knee tears, right? So it's a very, very low percentage of isolated injuries, right? It doesn't mean that they're not occurring. It's just that it's very rarely occurring in isolation. So when someone comes in and just had a major knee injury, chances are it's going to be something else, right, in isolation. Or if there is a posterior lateral corner injury, it's with something else, okay? Of the patients with posterior lateral knee structure injuries, 87% of those had multiple ligament injuries. So posterior lateral corner with PCL or ACL or something else. However, the overall incidence of posterior lateral knee injuries among all knee ligament injuries was 16%. And among all acute knee injuries with hemarthrosis was 9.1%. So if you have an ACL injury or you have a ligament injury within the knee, there's a 16% chance that you have a posterior lateral corner injury with it. And if you just have a big swollen knee with hemarthrosis, you have a 9.1% chance of having a posterior lateral corner injury. So if you think back on all the ACLs you treated over the course of time, there may have been some posterior lateral corner stuff going on with those, right? So previously we thought these were very, very uncommon, but it's accounting for around 15% of hemarthrosis knee patients, right? So it's not none, but I think the other part was this: only 2.1% of these folks were isolated posterior lateral knee injuries. So you're very, very rarely going to see these in isolation. You're usually going to see them with concurrent ligamentous injury. So I hope you're ready for your head to blow up in a good way, of course, because I have something that you're going to love. It's an evidence-based cheat sheet for LCL injuries. Staying up to date on the literature is a pain in the butt, and my butt hurts. But yours doesn't have to, because I've done the work and going out there and reviewing the literature. I've taken all the good stuff and none of the fluffy stuff and condensed it into a nice little cheat sheet. My promise to you is I'm going to catch you up to date on the latest literature on these ligament injuries in under 10 minutes. These babies are action-packed, but not too packed. We go over prevalence and incidence, common populations with this injury, anatomy, mechanism of injury, clinical examination, differential diagnosis, and all the different treatments, conservative and surgical. Best of all, this bad boy is free. So I'm going to leave a link in the description. Go ahead and click on that and download it. My promise, I want to catch you up to date in under 10 minutes. I hope you enjoy. Now, back to the learning. Any thoughts there before we move on, Kevin?
Yeah, I think that's helpful to know. So when someone comes in with, posterior lateral knee pain, but you're not suspecting any other type of ligamentous injury, it's probably not likely that they have a posterior lateral corner injury. Could be something else. Could be like a proximal gastroc or hamstring or something like that. But if there is trauma and you're suspecting other ligaments, maybe worth doing some tests to figure out if that is what it is. But maybe not worth obsessing and thinking everyone has this, because we know it is relatively rare too.
Yeah, for sure. I think we also just want to make sure that we're on the lookout for it. And kind of like the MCL, if certain tests are positive, we're probably just going to send back to the doctor because not only might they have a posterior lateral corner injury that may need surgery, but they might have concomitant pathology. They might have something else going on, like an ACL or something along those lines, where they may need a different intervention, right? Or at least we need to know about this to make an informed decision for their patients. All right. More information on prevalence and incidence. Posterior lateral corner injuries are commonly associated with cruciate ligament injuries, like we said. And the other one I thought was pretty interesting is the LCL is rarely injured in isolation. So if you look at injuries to the posterior lateral corner, part of the posterior lateral corner is the LCL, right? So if you injure your posterior lateral corner, there's a chance you injured your LCL with it. It's very uncommon to isolation injure the LCL, which is kind of interesting because that's kind of what I heard recently. And I feel like I've seen a few of these. Maybe I was just lucky to see these. I'm not really sure. But it seems as though the LCL is rarely injured in isolation. Oftentimes you have posterior lateral corner injury with it. And then if you have a posterior lateral corner injury, you probably have something else going on too, right? And this study was saying about 20%, 28% of posterior lateral corner injuries occur in isolation, and 72% had another ligamentous addition, like we had said. They're often associated with peroneal nerve injuries. So you might want to potentially check peroneal nerve involvement. 26.2% of posterior lateral corner injuries present with peroneal nerve involvement, which is pretty dang high, right? About a quarter. Which populations are injured? We don't have really great prevalence studies to tell us which sports are most common in, but they're basically in cutting and pivoting sports. So things like soccer, right? Football, basketball, all the same sporting populations where you see like ACL injuries, right? Like I said, they're previously thought to be very uncommon, but they're probably happening a little bit more than we may have thought, but usually in conjunction with other injuries. What is the mechanism of injury? So what might your patient tell you that might get you thinking like this might be a posterior lateral corner injury? You can have a direct varus stress, and that could be contact, right? Someone has a blow on the inside of the knee, pushes that knee to the side, could cause injury there. It also can occur with hyperextension of the knee. Of the few that I've seen athletes that get a blow to the knee that pushes them into hyperextension, but also gives them a varus stress. So you have the combination of the two is going to stretch that posterior lateral corner, right? They can also be non-contact in nature. If you have tibial external rotation, dynamic valgus, right? So same kind of mechanism of injury you'd see for like an ACL, MCL, could also tear that posterior lateral corner, right? Then obviously you can have a combination of all of those motions together, can give you trouble, right? What are your thoughts on that, Kevin? Do you typically think of people having dynamic valgus leading to posterior lateral corner injuries?
Yeah. No, but that kind of makes sense, right? I guess you said with the dynamic varus, right? It tends to be
Dynamic valgus. So if you're having dynamic valgus with tibial external rotation, that can cause a posterior lateral corner injury, but also an ACL injury or an MCL injury or meniscus injury. So if you have that mechanism, could be a bunch of things.
Yeah, I'd say historically it's probably been on the bottom of my list or not on my list at all.
Yeah, for
So
sure.
it will be good to consider, definitely.
Yeah, and there's a few like tests that you can try, but I think at the end of the day, if you're considering that someone has any sort of intra-articular pathology, you're going to send back to the doctor and just make sure there's nothing more serious going on, right?
Yeah.
Little background in the grading of injuries. So these are ligamentous injuries. So it's not like every injury is going to be a complete rupture. You can grade them, right? And this grading injury system is from Houston et al. And essentially, they're doing various stress testing at 0 degrees of flexion. A grade 1 injury would be 0 to 5 millimeters of lateral joint opening. They also grade these injuries based on the amount of tibial external rotation. So, grade 1 injury, you'd see somewhere between 0 to 5 extra degrees of tibial external rotation. For a grade 2 injury, that's 6 to 10 millimeters of lateral joint opening, or 5 to 10 extra degrees of tibial external rotation. And then grade 3 is greater than 10 millimeters of lateral joint opening, or greater than 15 degrees of tibial external rotation. That'll make a little bit more sense in a minute when we go over dial testing. But essentially, as you stretch this ligament more and more, if you stretch that posterior lateral corner more and more in the LCL, you start gaining additional tibial external rotation, right? So not only are you assessing for laxity with your various stress testing, you're also assessing how much tibial rotation they're gaining, right? And you can kind of see your LCL in this image right here to the side attaching to that fibula. So it makes sense that if you start to stretch that out, you're going to have a little bit more varus laxity and also some tibial rotation, just because that posterior lateral corner is going to play an important role from a rotation perspective. Anything to add before we move on, Kevin?
No, yeah, that all makes sense.
Okay.
So with that clinical testing of the LCL, if you do see some external rotation instability of the tibia as well, maybe a little posterior lateral corner.
Yeah, for
Yep.
sure. We'll talk about kind of surgical versus conservative approach, but once the posterior lateral corner gets involved, we have to be cautious, I guess. Cautious is probably the right word.
Hmm.
Little extra anatomy. We already talked a little bit about this. So the lateral collateral ligament is on the opposite side of the knee of the MCL. So lateral just means on the lateral side, medial means on the medial. Unlike the MCL, the LCL is kind of like a cord that attaches from the femur down to the fibula, where the MCL is kind of like a fibrous band. It's like kind of thicker in general. The LCL is just a fibrous cord. You can actually feel it pretty well. If you have your patient sit in like a Faber position on their back, you can palpate the LCL, and it does feel just like a cord, right? And like I said, it originates on the femur and it inserts onto the fibular head. Let's go into the anatomy of the posterior lateral corner. So like I said, the LCL does make up part of the posterior lateral corner. So it's kind of odd to injure the LCL in isolation, although you can. The second piece here is this is a beautiful picture. So if you're not watching this on YouTube, you can't see this. You definitely need to check this out at some point. Let's make it a little bit bigger just so people can really appreciate this. But anyway, I'm always afraid that I'm going to get hit with like a copyright restriction and get sued. So what I did is I drew the posterior lateral corner, right? And since my son is such an artist at this stage of his life, I used a lot of his instruments and tools to make something beautiful, right? Essentially, I'm going to list out the anatomy and then I'll try to point it out a little bit. But the posterior lateral corner, the primary structures make this up. Like we said, the LCL, the popliteus muscle tendon unit. So yes, the popliteus is a muscle, but the tendon where it attaches, it does behave a bit like a ligament. More about that later. The popliteofibular ligament, which has an anterior and posterior arm. The secondary stabilizers are the lateral capsular thickening, aka the lateral patellofemoral ligament, the fibellofibular ligament, the coronary ligament of the lateral meniscus, the lateral head of the gastrocnemius, and the long head of the biceps femoris. So a lot of stuff in there, that I don't think I ever learned in PT school. And before I did this lit review, I think I knew about 25% of those structures. How about you, Kevin? Are these familiar structures for you?
I think the fibellofibular ligament is the one that I knew most about.
Yeah, for
No,
sure.
yeah, a lot of that stuff is a good review or things I haven't seen in a long time. So, yeah.
Yeah, I mean, the anatomy is a little bit complicated. I can understand why folks are like, posterior lateral corner, what the heck is that? Obviously, there is a lot going on there, but we'll try to
Hmm.
make the takeaways pretty simplistic, because when you look at that structure, you're like, what the heck? There's so much stuff in there. I'd have to know about every single piece. I don't think so. But yeah, it's important to know there are a lot of structures in there. I think it's also important to just note that you have a bunch of dynamic stabilizers in the mix. So you have the popliteus, we have the biceps femoris, we have the lateral head of the gastroc, all cross over those joints. So when we talk about rehab in a little bit, those dynamic stabilizers become really, really important, right? Just to orient you a little bit, if you are looking at the YouTube version of this podcast, this is a view of the side of the knee. So you can see the femur bone, and you can see the tibia bone, and you can see the cartilage is in blue. And they have the fibula that's kind of front and center, but it's a little bit below the joint line. And then the LCL is that fibrous cord like we were talking about, right? And right behind it is a posterior lateral corner, the rest of it anyway. And you see how it's more posterior than the LCL is. So the popliteofibular ligament, as well as the popliteus, these are the major structures that we have to take note of for the most part, right? That making sense? Make it a little bit less complicated. And moving on to the biomechanics of the posterior lateral corner. So the posterior lateral corner is a primary restraint to varus stress and external rotation of the tibia. So if I'm sitting down and I point my toes out to my side, that's external rotation of the tibia. The posterior lateral corner is going to resist that, okay? The LCL by itself plays a primary role in varus support. Although the entire posterior lateral corner does, it's just the LCL does the brunt of that, right? The popliteus unlocks the knee. I'm sure we've all learned that in PT school, and also internally rotates the tibia, right? So if we wanted to try to strength train the popliteus, we could do resisted internal rotation of the tibia. It's kind of a weird motion, but if you're trying to protect that posterior lateral corner, grade 1, grade 2 injury where you're not considering surgery, you might want to think about training that, right? So kind of an interesting way to train the popliteus. Popliteus is also a knee flexor, so we can train that, right? We can train knee flexion, which the biceps femoris does the same thing. So a good way to rehab your posterior lateral corner injury patients. It has ligamentous qualities that resist varus stress as well. So a popliteus is kind of interesting because it's a muscle, but it does behave a little bit like a ligament as well in terms of acting as a stabilizer. That all making sense so far, Kevin?
Yeah, perfect. I think, like you said, it's good to know that there's a combination of static and dynamic stabilizers that make up the posterior lateral corner, and that we can, if there is some there's the lateral stabilizers have been compromised, the static ones, it might be good to work on dynamic stability. And I think, special consideration to what those muscles do might be helpful. In internal rotation of the tibia strengthening is not something we conventionally think about, but maybe could be helpful if there is some damage there, or we're trying to strengthen that. I think that's awesome.
Yeah, for sure. And I'm going to talk about this in a minute, but there's no research on how to rehab these conservatively, right? But for the grade 1s, grade 2, generally speaking, you're supposed to manage them those conservatively. So it's kind of like, what the heck do I do? If you
Mm,
know what the dynamic stabilizers are of that area, that's at least one way you can start, right? So to your point, I think that does help out to understand the anatomy a little bit. Just talking about those dynamic stabilizers, lo and behold, here we go. More biomechanics of the posterior lateral corner. So, which structures within the knee dynamically stabilize the joint, right? So, the lateral gastroc does. So, we just talked about the MCL in our last podcast and how the medial gastroc crosses right over that area. Same thing you have going on with that lateral gastroc, right? And the thing about the gastroc that I think we forget about sometimes is it does flex the knee, but it's also a plantar flexor. So, if you're doing any sort of hamstring curl, you're also doing a gastroc curl. I'm gonna start calling them gastroc curls, right? This is actually kind of interesting because I was in jujitsu the other week and someone was trying to knee bar me. Essentially, just means they're trying to bend my knee backwards, right? And I was fighting it a little bit, and eventually I tapped like a good student so I don't explode my knee. But after class, my gastroc was super sore. I'm like, that's weird. But I think sometimes we forget that the gastroc does prevent extension, right? So it is an important dynamic stabilizer for posterior lateral corner injuries. We also have the popliteus, which flexes the knee as well and also contributes to tibial internal rotation. So if we're trying to rehab our PLC patients, maybe we think about training that directly. Your biceps femoris also stabilizes that area. So again, resistant knee flexion, probably helpful for these folks, right? If you think about the biceps femoris and where it attaches on the fibula, one of the things you may notice in your patients after an LCL injury, and this was definitely the case for me, anytime I tried to put stress on my hamstring, it hurt my knee a lot, right? So if you think about it, anytime that you are doing a hamstring curl, it's tugging right in that same exact area as your LCL. So two things here. A, from rehab perspective, probably have to train these dynamic stabilizers. B, maybe we have to be a little cautious with how much we train them early on, right? And that's the same as any other injury. Early on, you protect it. Later on, you strengthen it, right? Same as a shoulder dislocation. If I just had like an anterior shoulder dislocation, I'm not putting people in a layback and strengthening them there, right? But eventually I have to. Same thing is probably going on with posterior lateral corner. We have to be careful, maybe unload these structures early on, but later on, we really have to hammer them and get them really strong. And the other piece I thought we tend not to think about much, but if you think about, let's say, IT band syndrome, IT band is really important for controlling various forces at the knee, right? So it's probably important for LCL injuries. And it may mean that you need to train your TFL, maybe you need to train your glute just because the IT band is kind of like a tendon for those muscles, right? So if we're trying to promote dynamic stability of the lateral side of the joint, we can work on all of these structures, right?
Yeah, that's all really good stuff. I think it's just having some good understanding of what structures make up the posterior lateral corner and then working backwards from that and seeing what muscle groups we can train to provide stability and symptom relief. So I think that's super helpful and a good way to just think about designing rehab programs in general.
Yeah, good stuff. All right, moving on. What else we have? So, moving on to your history and physical examination, right? What are these patients going to tell you when they walk through the door, or what do you have to be on the lookout for when you're considering there might be a posterior lateral corner injury? So, these can be traumatic injuries, right? So, if you have a blow on the side of the knee, which causes hyperextension of the knee or varus force, this can obviously create injury. They can also be non contact in nature. So, tibial external rotation. So, if you think about dynamic valgus, you've got femoral internal rotation and tibial external rotation. That can obviously cause MCL issues. That can cause medial meniscus injuries. That can cause ACL injuries. But it can also cause a posterior lateral corner injury. You're just rotating the knee. If I took someone's knee and just twist it in a full circle, you would tear all the ligaments there, right? So it does make kind of sense. If you have the same thing going on with the sport, you can create an injury to all of those structures in theory, right? What else might you see? You can see some local swelling, ecchymosis or bruising, or tenderness in the posterior / lateral knee. And when I had an injury to my LCL, and it's funny because I think I injured my LCL in isolation, I did actually have a varus force with my knee bent. So it's kind of like, the exact mechanism of injury for an isolated LCL injury. I didn't have any swelling within the joint. Like you do like a sweep test and there was no swelling there, but it was definitely puffy right along that LCL, right? So right where the LCL was lying, I did notice that. It was certainly tender. When I tried to put my finger on it and rub back and forth over it, it was certainly tender, right? And if you have joint effusion within 2 hours after an injury, or even later on, that's indicative of intra-articular pathology. So immediate swelling, maybe that means more cruciate ligament injury. If it's delayed, maybe that's more meniscus pathology, right? One thing to just keep in mind is that you can have a lateral meniscus injury, and that kind of sits right in that joint line, right where the LCL also lies. So we have to be kind of doing our due diligence to try to differentiate between intra-articular pathology or extra-articular, like the LCL or posterior lateral corner. From a gait assessment standpoint, you'll probably see more of this in chronic patients, not necessarily acute. You might see some standing varus alignment. So essentially when they're stand, that knee might be kicked out to the side just because they have so much laxity in that LCL. If you have an acute injury, these folks might just limp or not even allow that motion just because stretching the ligament feels so bad, right? You also might see some stance phase varus or a hyperextension thrust. And all that means is that when you take a step, when you're on that stance side leg, you may find that that knee kind of kicks into varus or hyperextension. And that might just be because they don't no longer have the stability on the lateral / posterior side of the joint. So the leg just kind of kicks into hyperextension or varus. What I will say is I have never seen this, I don't think, but it's at least something I can be on the lookout for. Have you ever seen any of these varus hyperextension thrust patients, Kevin?
No, not traumatically, but I was just thinking I've seen a few patients with posterior knee pain there with just their normal resting posture is a lot more tibial external rotated and more in a varus position. Did you see anything at all about a non-contact mechanism of injury where it's like due to postural alignment over time, or probably not, right?
Not that I have found,
Yeah.
No, I think most of it is more like contact in nature that ends up stretching this out a lot. But maybe in
Yep.
theory, you could stretch it over the course of time. I don't really know. Yeah.
Yeah.
I would say overall, this thing is not studied well enough,
Sure.
Maybe we'll find more of that over the course of time, but who knows? Moving on to objective tests and kind of similar to the MCL. I think the MCL has more research on this compared to the LCL and the posterior lateral corner. We don't really have sensitivities and specificities of these tests. So take this all with a grain of salt. Essentially, these tests were designed to check whether or not they think that the person still has an intact or stretched LCL or posterior lateral corner based on what we know about anatomy, right? So it's not going to be like the Lockman test where we really have a good idea of sensitivities and specificities, right? So I think at the end of the day, if these tests are positive, you're just sending them back to the surgeon so they can get some better tests via, let's say, MRI, which in some cases is not the best. We'll talk about that in a minute. But in terms of objective tests, what can we do? So the basic ones are going to be varus stress testing and 30 degrees of flexion. This is going to indicate isolated LCL injuries. I remember after I hurt my LCL and you assessed my knee, it hurt when I was bent, but it didn't hurt when my leg was straight. And at the time I was like, well, I think that's good. I think that means that I have good stability of my leg, right? But if you have varus stress testing at 0 degrees of flexion and you're noting that there is increased range of motion, that's going to indicate more extensive damage of the posterior lateral corner or one or more of the cruciate ligaments, right? So similar to, let's say, the MCL, if you are going to a valgus stress test, you're noticing a lot of laxity, probably indicates that there's more damage and maybe additional ligaments are involved. Same thing goes with varus testing at 0 degrees of flexion. So that's going to pick up an injury to the posterior lateral corner and maybe one of the cruciate ligaments. So if you're noting that there's increased motion there, not a good sign. Probably want to send them back to the doctor at that point, right? Like I said, not great sensitivity and specificity, but I think it just makes sense that with the lack of knowledge we have and the potential this could be something more serious, you probably do need to send them back to the doctor. Just because if you do have an isolated LCL injury, it actually tends to heal really well. But if you have, let's say, an ACL involved with it, that's a sticky wicket. Now we're talking about some additional procedures might need to be done. So you can also do what's called a reverse pivot shift test, which is essentially a pivot shift test. The patient is supine, knee flexed 90 degrees. You put a valgus force at the knee. We go into tibial external rotation, and we extend the knee. At around 20 to 30 degrees of knee flexion, the tibia will reduce, a posterior sublux tibia. So if you have posterior lateral corner, that tibia is going to be sitting posteriorly somewhat. And if we go into knee extension, it's going to pop forward. That's going to indicate a posterior lateral corner injury as well as a PCL injury, right? It's not good stuff. The other piece is that, and this goes for the MCL podcast, which I forgot to mention, I will be doing videos of all of these tests. So you guys can see exactly how it is, which means you got to subscribe to the channel because you're not going to know when I post it, right? So that's going to be super important. But I do think a lot of these tests are not necessarily common knowledge. I'm going to put together a whole bunch of different tests. So you'll have a battery of tests. You have a patient where you think they have a posterior lateral corner injury, right? Going on to more objective tests. This one's fun. It's called the external rotation recurvatum test. Patient's lying on their back. You stabilize the thigh. So essentially your hand is going to be right above the kneecap. You're going to be pushing the leg down onto the table. You hyperextend the knee, lifting from the big toe. This one's just funny because you grab the patient's big toe and try to hyperextend the knee. A positive test indicates a posterior lateral corner injury along with an ACL injury, right? So kind of an interesting special test for the ACL and test for the posterior lateral corner. We can also perform a dial test. This is the classic test for posterior lateral corner injuries. It's pretty much the only one that I knew of before doing this lit review, right? And essentially, the patient is on their stomach. I wrote supine again, so I messed that up again. Patient's on their stomach, and I think you can also do this in supine as well, just obviously at a little different angle. On their stomach, and then you're going to do this test at 30 degrees of knee flexion, and again, 90 degrees of knee flexion, right? And if you have greater than 15 degrees difference of external rotation, that's a positive special test. But do keep in mind, if you have a grade 1 or grade 2, you might notice 5 to 10 degrees of additional tibial external rotation, right? And that just means the injury is not quite as bad. If it's greater than 15 degrees, that would indicate you have a grade 3 or something that's more than that, right? And if you're testing the knee at 30 degrees, that's more indicative of a posterior lateral corner injury. And if you're testing at 90 degrees, that's more indicative of a PCL injury, right? So you can kind of bias one ligament versus the other depending on how much knee flexion you have. Here's what's also confusing. We can use a posterior lateral drawer test, which essentially is the same test that we just looked at for MCL pathology. The patient's on their back. We're doing an anterior drawer. They do it at 80 degrees of knee flexion. We take the foot, we put it into 15 degrees of tibial external rotation. And a positive test will be increased laxity on the involved side versus uninvolved side. And that's going to indicate a posterior lateral corner injury or an ACL injury or anterior medial rotary instability, is what we just talked about previously. And I think it kind of comes down to the fact that if you twist that knee bad enough, you're going to cause a lot of laxity, right? So if you're doing a drawer test, a posterior lateral drawer test, and you're noticing that they have laxity, you send them back to the doctor, essentially. They just need some more imaging at this point. So if you are suspecting that someone has a posterior lateral corner injury, maybe they don't have much laxity at 0 degrees, but you want to make sure that it's not a PLC injury. You do a dial test, you do a posterior lateral drawer test, and if you're noticing they have significant laxity there, I'm probably going to send them back to the doctor at this point. Does that make sense so far, Kevin? I know these are kind of newer tests that a lot of PTs don't have a lot of familiarity with.
Yeah, no, those are good. And I think the videos that you do will be real helpful. For the posterior lateral corner, where it said greater than 15 degrees, is that compared to the contralateral side? Or is
Yep.
that okay? It's not just more than 15 degrees of tibial
Yeah,
ER in
sorry.
general. Right. That's okay. Yep.
Yeah, I should have mentioned that. But literally, when they do the test, you look at both feet and you
Mm-hmm.
see how much rotation there is. And
Mm-hmm.
greater than 15 degrees difference from side to side, right? Because 15 degrees of external rotation is normal, right?
Yeah.
Depending on the study that you look at, somewhere between 20 or 30 is going to be normal, right?
Mm-hmm.
So
Mm-hmm.
if you've got more than 15 degrees difference side to side, that would be a positive special test, right?
Makes sense.
Yeah, sorry, I
Perfect.
should have definitely mentioned that. People are going to be diagnosed with posterior lateral corner injuries all over the place now.
Everyone's
So,
got it. Yeah, no, that's great.
If you guys like what you're learning about so far, then the next logical step is to sign up for the Fitness Pain-Free mini course. I've made an absolutely free mini course, and we go over 4 vital lessons for coaches and clinicians. The first lesson goes over how traditional schooling has failed us. Now, I'm actually a really big fan of education, and I think that physical therapy school actually prepared me pretty well to work with the average person. However, I really didn't learn how to work with the population that I want, which is people in the strength and fitness world. So I'm talking about powerlifting, bodybuilding, Olympic weightlifting, sport of fitness, and really people that just love working hard in the gym. And really my goal with the mini course is to help you understand how you work with this population to get them out of pain and keep them training. The next lesson is 7 reasons why people get hurt in the gym. So it's vitally important they understand the injury mechanisms or why people get hurt in the gym. If we don't understand why folks are getting hurt in the gym, it's going to be very hard to rehabilitate those folks because let's say we do get them better, they go right back in the gym and get hurt in the same exact way they hurt before. The other piece is if we want to keep these folks safe for the long haul, we have to understand the main reason why these folks get hurt in the first place so we can keep them in the gym training as safe as possible and minimize that risk of future injury. Next, we go over 4 simple steps for getting your clients out of pain. Now, rehab can be very complicated. There's a lot of systems out there that make it very challenging to figure out how to work with your patients. However, it really doesn't have to be that complicated. So I go over 4 easy steps you can follow to get your patients out of pain and back in the gym where they belong. Lesson number 4 is how to build the career of your dreams and earn the respect of your community. Let's face it, the reason why you take these educational courses is obviously so you can learn a little bit more, but really the deep-seated reason is because you want to have the respect of your community. You want your clients to come in, work with you and say, wow, Joe was great. He did a phenomenal job with me. Tell their friends, and their friends come to see you. And after a while, you're very valued and respected within your community. So I'm going to teach you how to do that. The second piece is that if you know these skills, it doesn't always mean you have a ton of patients going through the door so you can work with the population you want to work with, right? So you may be the absolute best coach in the world, but no one wants to come and see you because they don't know who you are and they don't know how good you actually are. So we'll teach you how to get the patients through the door that you want to work with. And lastly, we'll talk a little bit about the Fitness Pain-Free certification. This is the largest and most comprehensive educational course that I offer, but more on this later. So I'll leave a link in the description, in the show notes. Again, it's 100% free, really easy to download. Go ahead and do that right now.
So we can also get some imaging. This helps to rule in or rule out other pathology as well as posterior lateral corner stuff. Obviously, x-rays can be helpful to rule out fracture, right? We can also use an x-ray to identify soft tissue swelling, joint space widening or narrowing. In particular, lateral joint space widening, fibular head avulsion fractures, and anterior medial tibial fractures can be suggestive of posterior lateral corner injuries. So essentially, we may not be able to pick up a posterior lateral corner injury, but you're seeing some of this stuff on an x-ray. It just means, hey, you probably need an MRI to figure out what the heck is going on here, right? We can also do varus stress radiography. If you're watching this on YouTube, you can see the image here. This is a valgus stress radiography image, but the varus stress radiography test is the same. So essentially, you're x-raying someone's knee while doing a varus stress test, and that can quantify the degree of laxity, right? MRI can also be useful. It's very accurate for identifying posterior lateral corner injuries. However, it's much less accurate in chronic injuries, so greater than 12 weeks. What's the reasoning for that? Well, if you have a whole bunch of like swelling and inflammation, the MRI is going to pick up on that, but over the course of time, it may not. So if you have a posterior lateral corner injury and it's been a large period of time, and you get an MRI, you might not even find that it's an injury anymore, which is pretty interesting. And that was one of the first times me hearing that, right? But it's a good little pearl. So if a patient goes in and you're noticing a lot of these tests are positive, it's a chronic test or chronic injury, patient had negative MRI, that might be what's going on, right? So the other reason why MRI is useful is that it's going to be great for multi-ligament injuries. So if you are suspecting a posterior lateral corner injury, but potentially something else is going on within the knee, MRI is going to be kind of the gold standard to look at that stuff. So is that making sense there, Kevin? Anything new jump out at you or any comments?
No, totally. I think the greater than 12 weeks is interesting and something I hadn't really thought about, but does make sense. But I think like most of these injuries where if we are suspecting ligament damage, we probably want to try to get that MRI if we can over the x-ray.
Yeah, makes a lot of sense. That's all standard stuff. So it makes these posterior lateral corner injuries a little less, demystifies them a little bit. That makes sense. All right. What about differential diagnosis? We just talked about how posterior lateral corner injuries are rarely existing in isolation. So you probably just really need a good battery of tests for these patients because you might be finding things like ACL pathology, PCL pathology. So you should probably perform a Lockman's test. We should be looking for a posterior sag sign. We should be performing a drawer test. We should probably be looking for joint effusion. For isolated PLC or LCL injuries, probably not going to see joint effusion. For ACL or PCL or meniscus injuries, probably will see some joint effusion. We should be looking at end range pain. However, keep in mind, PCL injuries or LCL injuries can occur with hyperextension. So if I have pain end range extension, that may indicate that I have meniscus pathology, but it could also indicate that I have LCL, PLC injuries, right? And the other piece is joint line tenderness is a decent test for the meniscus, but your LCL crosses that joint, right? So I think you can kind of get someone into a Faber test and isolate that LCL and poke just on that, which may make it more specific to the LCL. But I think in general, if you're noticing a bunch of joint line tenderness, could be a meniscus injury as well, right? The last piece is that your IT band crosses right over that area. And I think the differential diagnosis is going to come from your history, right? Usually IT band injuries are not traumatic in nature. And also the location of symptoms. So usually for IT band pain, that's going to be a little bit above the joint line where the LCL kind of runs right along the joint line and kind of extends below it somewhat. So those are some of your differentiating factors there. Let's go over conservative versus surgical management. You have a patient that comes in, you think they have a posterior lateral corner injury. What do? You treat them, you send them back to the doctor. Who the heck knows, right? Generally speaking, posterior lateral corner injuries, and this includes isolated LCL injuries, which we'll talk about more in a minute, they're generally treated conservatively. So for the most part, non-surgical. This is for grade 1 and grade 2. Grade 3, they're generally surgical candidates. And what is one of the reasons why they're generally surgical candidates? We have some animal studies, and this is in rabbits. We have not been able to reproduce this in humans, right? So take it with a grain of salt. is that the posterior lateral corner, not necessarily the LCL in isolation, which we'll kind of get confused by in a minute, doesn't heal well in animal models. So the thought is, if your posterior lateral corner is injured, grade 3 injury, we don't think it's going to heal well. But this is based off of studies in rabbits, right? So take that with a grain of salt. That's one of the reasons why we consider doing a surgery, right? For isolated LCL injuries, so not the rest of the posterior lateral corner, just the LCL, grade 1 and 2 are treated conservatively generally, right? This is confusing to me, and I had to look into this a decent amount, but the LCL is an extra articular ligament, right? Just like the MCL. And generally speaking, extra articular ligaments are supposed to have decent blood supply. The MCL does. We know that heals well. The LCL, we know it has blood supply. We know that it does have blood supply to it, but some sources say it has poor healing. Before I did this lit review, that's exactly what I thought. It's just that we actually don't have good data on how well the LCL heals. I couldn't even find any rabbit studies or animal studies that were looking at its healing capabilities, right? But you will see some sources say it has poor healing, but they look for a citation. See if you can see back where they're getting that from. And I did not see any citations myself. So I'm not sure where that came from. But I'm actually pretty curious how well these things heal myself, right? And if you're a grade 3 isolated LCL injury, those can also heal well conservatively at a very high level. We'll talk about those studies in a minute, but I was under the assumption grade 3 LCL, you're going to need surgery, right? Because that thing didn't heal. So I had heard that at some point, and I had read that at some point, particularly after I injured my LCL. And one of the sources that said that was the Stat Pearls. You know how when you do like a PubMed review and you see that Stat Pearls citation comes up, which is like an online, continually updated resource, right? Like an encyclopedia. That said that the LCL doesn't heal, and it had 0 citations next to it. So I wish there's more information about that, but these can heal conservatively even with grade 3s. Any thoughts before we move on? Because I got some pretty cool information coming up next.
Yeah, I think it's just interesting to see. It's one of those things, like many others, that we just need more research over the course of time to make better clinical decisions. But it is encouraging. It seems like, a wide spectrum of these things can be rehabbed conservatively, and maybe a good place to start with most folks, rather than, kind of being afraid that there is some damage there and we need to refer for a surgical consult right away. We could probably have confidence that we can at least try to get the ball rolling conservatively and use our clinical reasoning to determine if we should refer out or not. So I think that's encouraging. And, I'm sure as more evidence comes out, those recommendations can get more confident.
Yeah, for sure. Okay. This is a cool study, right? And this was in isolated LCL injuries, which that doesn't typically happen, right? Usually the whole posterior lateral corner is injured together. This study was at American Journal of Sports Medicine, so good journal, 2010. It was treatment of MRI documented isolated grade 3 lateral collateral ligaments in National Football League athletes. So a couple cool things about this. So it's an isolated injury. We know it's a complete tear, right? Grade 3. And this was in very, very high level athletes, NFL athletes, right? And it was a very small sample size. So there's only 9 total players. But what's kind of cool is that 4 players went the surgical route, right? They got the LCL repaired, reconstructed. We'll talk about that in a minute. And the average return to sport was 14.5 weeks, which I got to tell you, that's fast. 14.5 weeks after surgery, getting right back out there, that's pretty dang fast. And then 5 players went non-op, and they got back on an average of 14 days, 2 weeks, grade 3, complete tear of that LCL. They're back to the NFL, like the highest level of sport and competition, a really tough cutting and pivoting sport, right? 14 days, 2 weeks. That blows my mind. And the next piece about this, which was crazy, is that they had very similar outcomes between the surgical group and the non-op group. The one difference is that long-term, there was slightly more varus laxity in the non-op group, right? But if you have a grade 3, you would expect there to be a lot of laxity, right? So at least this stands to reason that that LCL is probably healing to some degree, which kind of goes against what I was told previously, right? And what this suggests that there's that isolated LCL injuries, there's their potential non-op management is the best case at all grades, right? If you know that after 2 weeks you might be, good to go to play at the highest level, then grade 1, grade 2, definitely, grade 3, potentially, right? The only thing, and I'd love to see more longer term research, we all would, what happens 5, 10, 15 years down the line, if you leave a little bit of laxity in that knee, is that going to lead to more longer term arthritis, right? What do you think of this study here, Kevin?
Yeah, that was the first thing I thought about is how long term were they looking and what does it look like further down the road. But I think it is definitely good information to have that even grade 3, perhaps we could try to rehab conservatively. And 2 weeks is like no time at all. Really, you miss more time with a hamstring strain. So, yeah, I mean, that would be encouraging for sure. And then I guess I would just wonder too what position they were getting back to. Like, is there a difference between a wide receiver and a running back or, a lineman who, something like that? You just wonder if someone's doing more of the aggressive running and cutting, is it more challenging to get back that quickly? But again, like you said, it lends to the idea that we can even try to rehab these conservatively, no matter the grade, and just kind of see how we do. And I'm sure it's one of those things where whether you do surgery today or in 4 or 6 weeks, it probably doesn't make a huge difference. Or even in like 2 or 3 months, you could try to do conservative care and see how you do. And if you don't do well, maybe you get surgery, but we don't have to rush to surgery.
Yeah, that makes sense. And even the authors mentioned that these are professional football players, meaning that they probably have more access to care. I
Hmm.
think the other piece is that they probably have a lot of pressure to get back. So when they return to sport, I'm sure they didn't just strength test the knee, do all the tests, and the same like rigmarole you would go through for a post-op patient, right? They're probably getting back a lot faster. And just thinking about my own kind of isolated LCL injury, I was limping for a while. I probably had a week or two where I was limping. And then getting back to faster movement took a long time too. For me to do like a ladder drill took several weeks. And then really jumping off that leg took even more, I'd say 6 to 8 weeks. And what was kind of interesting about my LCL is that I would say around 10 to 12 weeks, I felt like I was getting close to normal. And after 12, it was like I didn't notice it at all. Just kind of like went away entirely. Even if I kind of stress it in like a figure 4 stretch position, favor position, which really stretches that LCL, I didn't tolerate that at all initially. But yeah, I've been lucky and it's gotten a lot better. But I wish I'd kind of known about this study prior, right? It would have made me a little more hopeful because I was very fearful going into this injury that this baby's just not going to heal. So kind of neat. You probably won't see too many isolated LCL injuries over the course of your career, but I think it's good from a critical reasoning perspective to know this study exists, right? Okay, so what do we do from a conservative management standpoint with these athletes? What are some general rehab guidelines? Just like with the MCL, but even worse, it's very low quality of evidence to inform treatment for posterior lateral corner or LCL injuries. And the research we do have poorly describes what they actually did, right? So that stinks. We don't really know what the heck we're doing. For grade 1 and 2 LCL ruptures, maybe do some immobilization for 2 weeks, followed by progression to a hinge knee brace with staged increase in range of motion, right? That was taken from citation number 7. I forget exactly what that was, but they're guessing. That's their best guess, right? To your earlier question about MCL issues, they said to immobilize these folks for 2 weeks. For the MCLs, they didn't. I'm guessing like maybe that period of time allows that to scar down a little bit so that from that standpoint, you get that ligament to heal. And then now we have a little bit of integrity. We can start to move it around somewhat. I don't know. For my own LCL, I didn't do that. For these NFL players, they definitely didn't do that. By week 2, they're out there running full force and playing, right? In the NFL study, for the grade 2 and grade 3, they braced those folks for an average of 4 weeks. So they're actually returning back to sport in a brace, right? But they didn't provide any details of the rehab program they utilized, right? From a rehab standpoint, citation number 8 actually has a non-op and a post-op protocol. So if you want to check out a study that kind of tried to figure out what a non-op and post-op protocol should look like, check out citation number 8. Put that in the description for you. But generally speaking, you're looking at progressive strength and range of motion, trying to train the heck out of those dynamic stabilizers. So lateral gastroc, popliteus, biceps femoris, IT band, and the quads. We're going to go from like linear running to multi-directional, and eventually sport specific. You got to think like, what the heck does the LCL do? What does the posterior lateral corner do? So it does resist varus force. It resists hyperextension. So we got to train all the muscles. They're going to help us with that. If we have a little bit less dynamic control now, because we stretched out those structures, what do we do from a dynamic structure perspective to gain some stability back? Anything to add from a rehab perspective conservatively, Kevin?
No, yeah, I think that covers the themes that we've talked about pretty well. Like your general rehab themes are going to apply here, and then a little bit more consideration to the specific dynamic stabilizers. But it sounds like that's a pretty good paper that's worth checking out, where they give a little more specifics for those structures and this type of injury. So good stuff.
Yeah, these podcasts are already so freaking long. It's like, man, if we were to do the entire thing, that'd be another like 60 minutes.
Yeah.
But I do think if you check out the ACL reconstruction podcast, the 12 keys, that's going to help you out a lot. And I think rehab is very, very similar. It's just the ligament does a little different things in terms of stability. So you just have to cater it towards the specific nature of the injury. All right. Conservative management, return to sport timelines, right? And this was in NFL players. So I think you probably can extrapolate a little bit to other populations. Just keep in mind, like we said, these guys are under pressure to probably do more. They've got a lot of physical therapy at their disposal. So take it with a grain of salt. This is for isolated LCL injuries. So for grade 1 injury, average days missed, 1.3, kind of like an ankle sprain. Grade 2, average days missed, 3.5. Grade 3, average days missed, 4.6. That's nutso. You know what I mean? And then it doesn't really match up with what I've seen clinically or my own injury. So there's something odd about this, but I do think it's also very hopeful, right? So for posterior lateral corner injuries, grade 1 to 2, this could take 3 to 4 months, right? So now when the rest of the posterior lateral corner is involved, it's definitely going to be a tougher rehab. And from a grade 3 perspective, we've had poor outcomes in these patients as well as instability. So if you injure the rest of your posterior lateral corner, grade 3, we know these folks don't tend to do well conservatively. So it makes sense they are surgical candidates. So if you have a patient where you're considering that they have a posterior lateral corner injury, we're probably sending them back to the surgeon. If it's an isolated LCL, probably going to be a better outcome. Does that make sense, Kevin?
Totally. Those are crazy numbers for the LCL. The NFL players are just different.
Yeah. Yeah, that's wild. It
It's not even missing a week. It's like your week preparing for the next team, and you're just playing.
Yeah, that's right. I guess it's one of those ones where they're like, well, he could probably play through this. That's kind of what it seems like to me.
Yeah.
And if it breaks all the way, you have an ACL or something like that, then we'll pick up the pieces afterwards. You know what I mean? But I don't think that's safe. I don't know that I would use those as guidelines for your athletes returning back to sport, right?
Hey friend, if you're liking this content, I have something I think that you're really going to love. And that would be a master course on rotator cuff related pain and rotator cuff tears. Having the patient come through the door and you don't know how to treat their pathology, that stinks. You feel like a fraud, you're just making stuff up, it's not good stuff. It's also pretty dang tough staying on top of all the literature that's coming out all the time. Well, guess what? I have done this for you by making a master course on rotator cuff related pain. Well, what kind of stuff do you go over in this course? I've got an evidence-based guide. We go over diagnosis and special tests, my favorite beginner, intermediate, and advanced exercises, how to modify your patient's training in the gym so they can keep on working towards their goals and not hurt themselves more, my favorite evidence-based manual therapy techniques for these folks, case studies on how to treat non-op and post-op patients, as well as the exact rotator cuff related pain protocol that I give to my patients when they come to see me with this common issue. Now that sounds pretty good, Dan, but how much does this cost? How does $1 sound? Whoa, $1? That sounds crazy. Why is it so cheap? It's mostly because I don't know how to run a business, but I do know about the rotator cuff, and I'll teach you all about that. This all comes with a subscription to Fitness Pain for Insiders. It's $1 for a 1-week trial and $25 per month afterwards. However, you can cancel at any time. If you don't like it within the first 7 days, just tell me. I will cancel and refund for you. Plus, I have a lot of other really good courses in there as well. We have master courses for cervical radiculopathy, lumbar radicular pain, lateral ankle sprains, and what I'm working on next is, you guessed it, your favorite, shoulder instability. So click on that link in the description. It's $1. Go ahead and get started, and I'll see you on the inside.
Let's talk a little bit about surgical treatment. Now, who are going to be good candidates for surgical treatment? So for grade 3 injuries, particularly for those posterior lateral corner injuries, not isolated LCLs, you're going to consider surgery. You can also consider surgery for failed grade 2. So if you have maybe a grade 3 LCL injury that failed conservative management, you can consider surgery. If you have a posterior lateral corner injury, grade 2, that fails conservative management, you can also consider surgery, right? So these tend to do well. Generally speaking, they have good to excellent outcomes, and they also have good knee stability. So after they do the surgery, they do various testing, they take a look at the dial, they look at tibial external rotation, and it seems like it does restore knee stability, right? Other surgical candidates are going to be multi-ligament knee injuries. So think about your ACLs as well as your PCLs. In terms of surgical technique, just like with the MCL, you can repair it or you can reconstruct it. Now, where would you tend to see more repairs? Usually these are going to occur with bony avulsion. So if it just pulls off right by the bone there, and these are generally performed with less than 3 weeks after the injury. So think about your acute tears, right? If you have an acute tear of the LCL, right, and you let it go for longer than 3 weeks, you might not be able to repair that anymore. But if it's a fresh injury, the tissue, you can still pull it back over and repair it down, right? The reconstruction is more often used in mid-substance tears, and usually this is in patients where more than 3 weeks have gone by, and it's more of a chronic injury, right? It can also be used if there's insufficient tissue. Let's say you have an acute injury and the tissue looks great, you can repair it. If you have an acute injury and the tissue doesn't look good, the surgeon's like, I don't think I can repair this and have it be a good outcome, they'll consider reconstruction, right? There's also a variety of acceptable grafts and procedures, just like we learned with the MCL. And there's no difference between reconstruction and repair generally from an outcome perspective. So it's not like you're pushing early for that repair, like, oh, you just had the LCL injury, need to get the surgery done right away. If you wait a little bit longer and you have to reconstruct it, doesn't seem to change your outcomes, right? Just that the type of surgery you get is probably going to depend a lot on the individual. Any thoughts there, Kevin?
Yeah, just with the reconstruction with the graft type, were you seeing similar things as like the ACL, like they're using patellar tendon or a hamstring tendon, or is it often cadaver? Did you come across that?
It's funny because I figured you might ask that question, I tried to look and I didn't see anything specific. No, but they did say there could be a variety of different options. So I don't know if they have. I would be surprised if there was data that was looking at graft type and outcomes, right? Although that might exist at some point somewhere, but just given that this is not very common as an injury, and I think it'd also be really tough to control for all the different variables, just because you're often seeing these in conjunction with other injuries. So you're going to be looking at, let's say, one graft type with an ACL and a PCL, right? And another graft type at the PLC, right? Without an ACL or with a PCL. And those numbers are probably going to be all over the place from an outcome perspective, just because you have multi-ligament injuries at this point. It would be tough, I think, to design a study that was only posterior lateral corner with different grafts. Although maybe they will at some point, but I just don't think that we probably have that data right now, All right. What about concomitant ACL and PCL tears? Because oftentimes these are happening in conjunction, PLC with ACL or PCL. So if you don't repair the PLC, the posterior lateral corner, increases strain on the graft ACL and PCL reconstruction. The other thing that happens is if you don't repair the PLC and you just do the ACL or the PCL, that does not normalize kinematics, right? And I think what a lot of surgeons end up doing, right? And it's not like I'm there seeing this, but I hear this from surgeons, right? Is that they will look at the stability of the joint. They'll do like a pivot shift. They'll do a surgery, right? Let's say ACL reconstruction. Then they'll do the pivot shift. And they'll say like, all right, it doesn't look good. Let's do an LET, right? Or they may do that and they'll say, all right, we need to do a repair of the posterior lateral corner because we're still not as stable as we'd like to be. So I think a lot of these decisions might actually be occurring when the patient is under anesthesia, right? If they're not happy with the amount of stability the joint has, maybe they add additional things. But I think the takeaway here is that if you do have a posterior lateral corner injury with an ACL, with a PCL, you probably have to do a reconstruction repair of all of these structures, right? And when you reconstruct the PLC with the ACL and PCL, you tend to see better kinematics and it reduces forces on those grafts, right? So it seems like you probably have to reconstruct and repair all these structures together. Unlike that MCL, sometimes we're just going to let it go, depending on the grade and whether or not you end up achieving some more stability of the MCL prior to surgery. We're not seeing that with posterior lateral corner injuries. Probably have to reconstruct that as well. Let's talk about rehab guidelines. And this is coming from a paper in 2024, which is pretty cool. Posterior lateral corner of the knee, an update on current evaluation and management strategies. Same one we've been talking about the entire time. They did give some rehab guidelines. Keep in mind, a lot of this is based on consensus from surgeons, basically what they think is most appropriate. We haven't really parsed out if this is actually going to relate to longer term outcomes, right? Or re-tear rates or anything like that. Generally speaking, there's going to be a period of time of non-weight bearing, which may be as long as 6 weeks. However, there are some studies with earlier weight bearing and even immediate weight bearing showing similar return to sport and similar outcomes, right? So if you have a patient after this procedure, you may see non-weight bearing, maybe not. It's probably based on the surgeon's preference, right? Early on, we're delaying knee flexion, so maybe limit it to 90 degrees for the first 2 weeks, and then range of motion is tolerated afterwards. The goal is full extension range of motion. I did say that right. And normal gait by 8 weeks. And the goal is full flexion by 12 weeks. So full extension first, followed by full knee flexion afterwards. And from there, it's just progressive strength and neuro re-education and a phased rehabilitation approach. If you guys want to see that, you can check out our ACL recovery 12 keys. I'll put a link in the description, link in the show notes for you guys there. And then if you wanted to check out a protocol after posterior lateral corner reconstruction, check out reference number 8 because they actually had a full protocol there, which is pretty cool to see. Anything to add, Kevin?
No, yeah, that makes sense. I'm sure, like you said, it will vary depending on the surgeon a little bit. So you definitely want to check on that. And like I said, I think in previous episodes, if surgeon offices are always pretty open to sharing that information if they don't come with a protocol. And I'm actually surprised how many patients we get post-surgery without protocols. It's like, I feel like when I started, even, like 6 years ago, I would see any post-op come with a protocol. And I don't know if it's just at Champion, they're just like, have fun, or you don't need a protocol. And yeah, most of the time it's okay. But sometimes I like to call and check and just make sure that what I want to do is appropriate. So they're always open to that. And I think that's good general guidance. But if you need specifics, just call the office and they'll share with you.
Yeah, it's a really good point. I think that's probably the same thing I've noticed. And I don't know why that is, right? But essentially, earlier on in my career, I would always see a protocol. Almost always a patient would come with a protocol. Now I'm seeing less and less of that. And like you said, I'm not sure if it's because maybe some of the doctors trust us or maybe that's just a trend, right? But for like a new grad, that's probably bad.
Yeah.
If someone's coming out, they're like, posterior lateral corner, what is this? That would have been one of those injuries where I'd have like a new eval and I would go into the room, right? And I didn't know what they were dealing with. And they're like, oh, I had a posterior lateral corner injury. And I was like, okay, let's have you do some quad sets. I'm going to go in the other room and look up what the heck a posterior lateral corner injury is and what a repair is and figure out what I'm supposed to do and not what I'm supposed to do, right? It's one of those guys. All right. What about return to sport rates after someone's had surgical reconstruction repair of the posterior lateral corner? So this is based on a consensus statement in 2018. A whole bunch of surgeons kind of came together. And they're trying to figure out how long you should wait before you return to sport. It's not actually showing the actual return to sport rates, but the consensus said that we should probably be waiting at least 9 months. Just keep in mind, these are commonly associated with multi-ligament knee injuries. So we're looking at like an ACL and a PCL on top of that. So we already know if the ACL is involved, we're waiting for at least 9 months, right? So that might be one of the reasons for that 9-month mark. But for posterior lateral corner injuries in general, it's going to take a while. This is not something that gets back unless you're in the NFL, within 14 weeks. So maybe I don't know. That was an isolated LCL. It's not the posterior lateral corner, so I don't confuse folks, right? But these do take a long time to come back. We have a little research from Morris et al. In 2021. They're looking at 10 studies, and these were looking at posterior lateral corner injuries, posterior lateral corners repairs or reconstructions. But all the patients included in this study also were multi-ligament knee injury patients as well, right? So to my earlier point, these are posterior lateral corner repairs, but they also have other ligaments involved, right? And their average return to sport time was 10.5 months, right? And the sports were not noted. I tried to look and see if they talked about which sports were involved, although they did say that multiple sports were included, just because if you're getting back to something like soccer, probably going to take a little bit longer than getting back to, let's say, weightlifting, right? So if they have weightlifters included in the studies, that's going to screw up the results. And I got to tell you, I think some of my return to sport numbers have kind of changed in my mind over the course of time. So I just reviewed an article from Doubt et al. In 2024, and they're looking at ACL reconstruction patients. And they were looking at a battery return to sport test. And at the 10-month mark, only 27% of those athletes were passing the battery of tests. And at the 12-month mark, around 75% of them were passing the battery of tests. So these were just ACL reconstruction, not like multi-ligament knee injuries. So one of my thoughts more and more is that sometimes it's not reasonable at that 9-month mark to return athletes back. And I've been frustrated by enough patients over the course of my career that 9 months are not back to where they should be, right? And the doctor maybe told them that 9 months was the mark. I think sometimes that 9-month mark is not reasonable. And I think some of the more recent, better research is showing that it isn't, right? So maybe around a year is something that's a little bit more reasonable to tell our patients, right? And even then, that's only 75% of folks. So I don't know. Any thoughts on this research paper here or at return to sport in general, Kevin?
Yeah, that's good. I think, like you said, it's just always important to keep in mind that return to sport is a combination of time and criteria. And it's important that the patient knows that there's not anything magical about 9 months or, 7 months or 12 months. It's just correlates with some of the criteria based return. So, we have to make sure that patients are hitting certain strength numbers and obviously range of motion numbers and performance tests before saying you're good to go back to sport. And just because we thought this was the timeline early on, that timeline's very variable. And having that conversation earlier rather than later is a good thing. So they're aware what you're looking for in your return to sport testing. And that time is a proxy for that, but it's not the be all end all by any means.
Yeah. I think that one of the things would be a little bit useful for us as physical therapists, for the surgeon community, and I don't think any surgeons are actually listening to this, so I'm probably just like talking to the wind here, is that, yeah, the time is important, but so is that criteria, right? Because I can't tell you how many times I've had a patient, month 9, they want to get back, doctor says it's okay, or even month 6, right? You see that post-op ACL reconstruction, where like that quad still looks bad. Your knee hurts when you jump, cut, change direction. You're not using a knee strategy. We have to have that talk. And it becomes like this heated discussion of like, well, the doctor said this. And then the patient is upset. The patient's dad is upset. Patient's mom's upset. Surgeon's upset. And it's like, I'm just trying to keep my patient safe here. And what I will say is that if safety is the most important thing, obviously this criteria is important. But I do feel that oftentimes the surgeon is not on board with that. But some of them are, that's a generalization that's not helpful. But hopefully find good surgeons you work with mostly that value this stuff, right?
Yeah, just a quick note on that. Just an example. I had a new patient this Thursday. She's like 4 months out of ACL reconstruction. Second time, I had one on the other side. Lives in New Hampshire, so just did most of her early post-op there and came down for testing and was cleared by her PT and surgeon to start running at 3 months with no tests to guide that. So she has a little bit irritated knee and a 53% quad symmetry. Shouldn't be running yet. Doing a little bit of higher level plyometrics. Probably shouldn't be doing that yet. And last time returned to sport at 9 months, arbitrarily at 9 months because the surgeon cleared her with no testing. So, we do hear this stuff a lot, and a lot of surgeons are still operating that way, and a lot of PTs are operating that way. And that's where we can definitely do better as a profession. Just explaining these things to our patients, because think about like healthcare costs and stuff like that. How much does a second ACL surgery cost? And could that have been prevented if you went back with the right criteria in the first place? But so many things along the way we're just clearing people for without testing. And that applies to ACL, but it applies to, I think, just the whole rehab process, but specifically post-ops, right? I mean, we have reconstructed something and it's in a fragile state. We can't go put a whole bunch of force through it if our muscles are super weak. And yeah, it's the challenging part of being a PT and frustrating part for sure.
Yeah, for sure. I mean, I was in a sports clinic before Champion, and we didn't even own a handheld dynamometer, right?
Mhm.
We were guessing the entire time, which is kind of crazy to think about. But one of the biggest things that I hear from students and kind of like online mentoring programs that we're associated with is that the clinic doesn't want to buy a handheld dynamometer, which blows my mind because there's so cheap options. A Tindac is like $160 and you get a
Mhm.
ton of data with it, but it's just a huge barrier to entry for a lot of folks. So yeah, I think that we got to be better. You know what I mean? I can understand it is expensive, but at least from a sports physical therapy perspective, we probably do need to be better, right? Not to shame anybody. You
Yeah.
guys need to get handheld dynamometers, but yeah, this stuff is really important.
Yeah. Last thing I'll say there is like what you just said, I don't like acting like we're the ones that know it all and everybody else is dumb for not doing it right. I think there is just a lack of knowledge sometimes, but also it's just, it comes back to just being honest about what you're good and not good at treating. And so if you don't have the right equipment, there's nothing wrong with saying, we don't really treat ACLs at this clinic, or we don't do post-op LCLs or posterior lateral corner injuries, just because that's not our specialty. And they should refer to someone who does that as a specialty. Just like if someone comes into our clinic with a vestibular issue or a concussion, I can't see them. Maybe there was a point where I could years ago, but I haven't seen it for so long. We need to be good at saying, like, even at the point where wrist and hand, I'll be like, they're better off seeing Scaduto or Dave. I'm not good at that at all. So I think
Yeah.
that's it. It's not, we can't be good at seeing everything. And some of that comes with equipment and just knowledge on outcomes and how to get good outcomes and what tests to do and stuff like that.
Yeah, for sure. My neighbor is a certified hand therapist. She's an occupational therapist. I talk to her about hand stuff all the time.
Hmm.
Her knowledge like blows me away. I'm like really jealous. I don't know. And plus she works with hands all day long. Like she
Hmm.
knows all the intricate bits about post-surgical protocols and like the stuff that we're rattling off the top of our head with ACL reconstruction. She knows that about like four corner wrist surgery, right? Like all the stuff that we have heard once in school or maybe not at all. It's like the
Hmm.
posterior lateral corner. They know about that stuff. So I almost feel like it's malpractice if I don't refer out,
Yeah.
to someone who really understands it better, unless it's
Hmm.
straightforward. And I really don't think I'm screwing someone up. So
Yeah.
yeah, good point, Kevin. So now that you're an expert with LCL and posterior lateral corner injuries, you might not know about the other side of the knee or MCL injuries. And I'll tell you what, MCL injuries are much more common. We have a video for you. We'll teach you everything you need to know about MCL injuries. I'll leave a link in the corner up there by Kevin's head. Go ahead and click on that, and we'll see you there.
If you're watching this on YouTube, please, please, please hit that like button. Consider subscribing to the channel if you enjoy this. If you're listening to the podcast version of this, please give me a 5 out of 5 rating. It helps tremendously. And lastly, if you want to go that next step and support me further, consider subscribing to Fitness Pain Free Insiders. So Insiders is like Netflix for physical therapists and coaches working with painful folks in the gym. You've got access to 100 plus webinars, ebooks, and courses. More recently, I've been taking all of my best content from YouTube. I've been taking out all the ads. I've been organizing it in a really step-by-step fashion in an entire course so you can easily go through it. And I add additional pieces to this to enhance your learning, right? So I just finished up my lateral ankle sprain course. And one of the big things I added to this was a protocol. So essentially, what do you do week 1, week 2, week 3, week 4, week 5, 6, 7, 8? You know me, I like working with athletes. I like working with really fit and strong people. So it's going to be a lot more robust than your typical protocol. Also, you have access to me. So inside of Insiders, you can leave a comment and I'll get right back to you. I also have physical therapy CEUs inside of Insiders. So if you take the course, Essential Coaches Series, get a bunch of CEUs. And what's even better is you can start for just $1. After that, it's $25 per month. It's going to be the cheapest CEUs you can get. It's by far the highest value program that I offer at the cheapest price. So head over to fitnesspainfree.com, click on the program's link, and then click on Fitness Pain Free Insiders to get started. I'll also leave a link in the show notes where you can check it out.